Good evening, everyone. Welcome to CTAC's patient input consultation on Truvada as HIV PrEP. Thank you for joining us. CTAC is Canada's non-governmental organization led by and for people living with HIV and co-infected with HIV and Hep C. Our focus is access to treatment. We've been working on access to treatment issues since 1996, and we work with a range of people in the community, in government, and in industry. Tonight's webinar is about Truvada for HIV risk reduction. Truvada is a medication, a tablet, that contains two chemical compounds, anthracycline and tenofovir disoproxil fumarate, in 200 and 300 milligrams respectively. Truvada for HIV prevention is taken daily in combination with safer sex practices, or PrEP, or pre-exposure prophylaxis, to reduce the risk of sexually acquired HIV-1 infection in adults at high risk. We'll have a chance to unpack this as the webinar unfolds. This is what is known as the indication or the prescribing use for Truvada for HIV PrEP. And that's basically what we're talking about. That's what the pills look like, as made by Gilead, the manufacturer who holds the Canadian patent on Truvada. And so what are the purposes of our webinar tonight? First, I'd like to inform you about the drug approval and marketing process in Canada, except the process in Quebec. Quebec has a different process. I'd like to provide you with some basic scientific medical information about daily Truvada for HIV PrEP. Thirdly, I'd like to provide you with an opportunity to contribute to CTAC's patient group input submission on Truvada for HIV PrEP via an online survey, and you'll be provided with the link to the survey at the end of the webinar, and Melissa will also follow up with an email. And finally, I hope this webinar will give you information and knowledge to support CTAC's efforts to have Truvada for HIV PrEP listed for cost coverage on public drug insurance plans throughout Canada. What are the limitations of tonight's webinar? Well, firstly, I can only hope to give you an overview and summary of the information on Truvada for HIV PrEP, and hopefully I can do so in fairly plain language. I will not be presenting comprehensive trial data on Truvada for HIV PrEP. I will only be presenting data on Truvada taken daily for HIV PrEP. There have also been studies of intermittent use or event-driven use of PrEP, but we will not cover those. Nothing in the presentation tonight is medical advice, nor is it an endorsement of a specific commercial product, brand, or company. Here's the agenda. First, we'll go over the common drug review and market access. Then we'll look at some of the components and key attributes of Truvada. In other words, why are we talking about Truvada in terms of HIV risk reduction? Why is it the medication that we're focusing on? We'll look at some of the clinical trial and real-world data related to the use of Truvada daily for HIV PrEP. Then we'll have an opportunity for a Q&A. I'll unmute the phones, and people can use the chat pod in the Adobe Connect platform. And finally, we'll provide you with the online survey link and talk about next steps. I'm now going to play a video that CTAC has developed in our CTAC Talks series which explains in a few short minutes the common drug review process in Canada.
Canada has a unique healthcare system, and sometimes it can be complicated to navigate. Canada's healthcare system is made up of 13 separate provincial and territorial programs and 6 additional federal plans, making healthcare in Canada a shared responsibility between the federal, provincial, and territorial governments. A drug can take as long as a decade to develop, and our regulatory review bodies might take as many as 5 more years to conduct thorough reviews. So what's going on during that time, and how do medical treatments get from clinical trials to a public insurance plan? Once a pharmaceutical manufacturer has created a new treatment or molecule, they must take it through clinical trials before bringing it to market in Canada. These trials evaluate whether a drug works and whether it's safe. A drug can take years to develop and study, with clinical trials often involving hundreds of people testing the drug. Manufacturers will create many molecules, but only those that prove effective during clinical trial are developed further. Some molecules are developed and never advance to become a treatment. It is important to consider that treatment development costs a lot of money, and manufacturers will generally seek to recoup those costs. When the manufacturer is confident that they have a competitive, effective treatment, they will submit the drug, along with clinical trial data, to Health Canada for review. Health Canada reviews the drug to determine if it provides clinical benefit and if it is safe. Once Health Canada concludes that a drug is safe and likely to provide clinical benefit, it is approved for sale on the market and can appear on private insurance plans. However, if a drug is to be listed in most of Canada's public formularies, the process is long from over. These are the public drug plans that many Canadians depend on in order to access essential medications. After Health Canada approval, the drug in question is reviewed by another body, the Canadian Agency for Drugs and Technology in Health, or CTAC. This agency is funded by the federal and provincial governments, except Quebec, which has an independent process. CTAC oversees a process called the Common Drug Review, or CDR, which conducts a review called Health Technology Assessment, or HTA. Many countries conduct HTAs, and there are different ways to measure health technologies. An HTA is conducted not just on medications and drugs, but also on any health technology, like a new pacemaker design, for example. Ultimately, the Common Drug Review seeks to answer the question, is this treatment cost-effective, and will it provide improved clinical benefits to Canadians? The Common Drug Review will assess the drug for listing on public insurance plans and must conclude whether it can provide equal or improved clinical benefit compared to its cost, and whether that makes it more cost-effective than similar treatments. How much money should be spent to achieve how much clinical benefit? Once the CDR concludes its assessment, it sends a recommendation to all health plans, federal, provincial, and territorial, as to whether or not the provinces should cover the cost of this medication and list it on their plan. The CDR will suggest that the provinces either A. list the treatment, B. list the treatment with clinical criteria and/or conditions, C. not list the treatment at the submitted price, or D. not list the treatment at all. Most treatments do not get an unconditional listing suggestion, and the majority are either not recommended for listing or recommended with conditions. In fact, in many of their reviews, the CDR has rejected or suggested not to list at a manufacturer's submitted price. Listing recommendations from the CDR are not binding or final. The provinces and territories receive the recommendation and are free to review the drug against their own standards or make their own conclusion from the Health Canada and CDR reviews. This allows provinces to realize local priorities and more closely manage provincial healthcare needs based on their budgets and populations. Each province does independently, as each is the public payer of their respective province or territory. While many provinces and territories conduct their own reviews, some smaller provinces tend to follow the CDR recommendation and list or not list accordingly. As new drugs are developed and new needs are realized, provinces and territories must be vigilant to maintain a public listing that addresses contemporary local realities and responsibilities. Often, older treatments must be considered against newer treatments to see which contributes the most value for the most reasonable cost. This system is designed to review and respond to new treatments as they are developed, while allowing room for both price evaluation and regional healthcare priorities. Conducting HTA reviews at several levels with room for conditions allows provinces and territories more control over their public plans and healthcare mandates, while still allowing Health Canada and the CDR to review every treatment at the federal level. Timely and reasonable access to effective and safe medicines is a healthcare priority for Canadians, and while the processes described here account for cost, safety, and efficacy, some critics worry that they are redundant, duplicative, and very costly. Additionally, some critics note that the multiple points of review have resulted in some drugs being available on some public plans, but not others. Therefore, not all Canadians have access to the same treatment options. Is there a better way to realize our healthcare priorities at a reasonable price without rushing our review of safety and efficacy? Is there a better way to realize our healthcare priorities at a reasonable price without rushing our review of safety and efficacy?
In the chat window, Melissa has just provided a link to the video. And you'll be able to access that on our website. We apologize for the echo. Moving right along. So let's talk about Truvada's approval and access to Truvada. Truvada has been approved and sold in Canada since 2006 for the treatment of HIV, but as you're probably aware, Truvada is only one component in a complete combination or regimen for the treatment of HIV. Truvada for the treatment of HIV is currently listed on all public drug insurance plans, also known as formularies, in Canada. Since about 2012, HIV-negative people have been using Truvada for HIV prevention or risk reduction. And this is true in Canada as well. Most of the people who have been prescribed Truvada for PrEP have been in Canadian cities, larger Canadian cities, such as Montreal, Toronto, and Vancouver, the MTV. And doctors have been able to prescribe Truvada for PrEP off-label. This is a perfectly legal practice, and all off-label means is for an indication or purpose other than for which the drug was approved. To date, only Quebec has offered public drug plan coverage for Truvada as PrEP. A couple weeks ago, Health Canada approved Truvada for HIV PrEP, and physicians, as a result, no longer have to prescribe it off-label. The next step in the process towards public listing of Truvada for PrEP is the Common Drug Review. The Common Drug Review has begun the process of evaluating Truvada for PrEP. Note that Quebec does not take part in the CDR. As our colleague Adam referred to in the video we showed, the Common Drug Review looks at economic value in the context of budget. So is there a social value in Truvada for PrEP over other similar drugs? And should this drug be listed on public formularies? At the end of the day, CDR, the Common Drug Review, will bring forward a recommendation with reasons. As part of the Common Drug Review, patient groups like CTAC can make submissions. At the end of the webinar, we'll provide you a link to an online survey, and we'll take into account your opinions and knowledge and experience as part of our submission on Truvada as PrEP. So what are the components and key attributes of Truvada which make it appropriate for PrEP? Well, it's one pill, and it contains 2 antiretroviral drugs, and these drugs are both part of a family of, or a class of drugs called nucleoside reverse transcriptase inhibitors, or NRTIs for short. These drugs block HIV's reproductive life cycle and indirectly increase the number of HIV-fighting immune cells. So effectively, they kill HIV before it can reproduce and strengthen the immune system. So Truvada has some attributes that are key to its effectiveness as HIV risk reduction or HIV prevention. Truvada is active in the body for a long period of time after it's taken, so it has a durable effect over the long term. Truvada effectively penetrates beyond the blood to the genital tract and other mucosa, which are important in the immune system. And tenofovir, one of the drugs, has a high barrier to drug resistance, which is important. Truvada can be taken with or without food and has favorable safety and tolerability profiles. On the previous slide, I talked about the penetration of Truvada. And this is gauged in terms of its maximum intracellular concentration. So we see that Truvada reaches its maximum concentration in rectal tissue in about 7 days, in blood in about 20 days, in the cervix and vagina in about 20 days. And as of now, we don't have any data on concentrations in penile tissue or tissue lining the penis. What about the side effect profile of Truvada? We know from 2 major studies of Truvada for PrEP, iPrEx and the Partners PrEP trial, that the side effect profile is fairly moderate or on the lower end. People reported diarrhea or abdominal pain, infections, headache, depression and anxiety, and back pain. I think it's important to note, though, that these type of adverse events were also reported, and sometimes reported at higher rates, by people taking a placebo. In the same trial, people were given placebos and other people were given Truvada. It's worth noting that people taking Truvada, either as PrEP or as treatment, have had abnormal laboratory results related to their bone mineral density and the indicators of their kidney function. Specifically in relation to PrEP trials, we saw that 0.003% of iPrEx and Partners participants discontinued participation due to kidney-associated laboratory abnormalities. However, subsequent studies of people taking Truvada for PrEP have shown that the bone mineral and kidney function lab changes are reversible once somebody stops taking the medication. And I provided the citations there because this is recent information and evidence which has come out since the time the iPrEx and Partners trials were reported. What about the clinical trial results? The Truvada product monograph, and Melissa's provided you with the link to that, is part of the package of documents that is provided by Gilead to Health Canada so that Health Canada can review the safety and efficacy and the marketing material. A key statement from the product monograph, as approved by Health Canada, was the iPrEx study and Partners PrEP study support use of Truvada to help reduce the risk of acquiring HIV-1. It's important to note, I think, that Health Canada did not review more recent clinical studies of Truvada for PrEP amongst gay and other men who have sex with men, including trans women, who are at heightened risk of HIV. And I'm referring in particular to the PROUD and iPrEx studies. Gilead negotiated with Health Canada to submit trial data that it had submitted to the regulator in the United States so that it did not have to supplement its file, so to speak. Who was in the iPrEx trial? Well, it was men and transgendered women who have sex with men at evidence of high-risk behavior for HIV infection. There were two arms to the study. People were given Truvada and took it orally each day, or they were given a placebo. And 29 people, or 1%, reported current identity as female. This was the trans population in the study. All subjects in the iPrEx study received monthly HIV testing, risk reduction counseling, condoms, and management of sexually transmitted infections that were diagnosed. So what are the results? In iPrEx, there was a 42% risk reduction among the people who are taking Truvada for PrEP when compared to the group of people who are taking the placebo. I think it's important to note that only half of the participants in the iPrEx trial who were on Truvada took it as prescribed. In other words, took it daily. However, among those who took Truvada 90% of days or more, we saw a 73% risk reduction. Stated plainly, the more people adhered to the medication and took it as prescribed, the greater the protective effect against HIV infection. Another important aspect of iPrEx was that the people who reported more risk behavior and more recent risk behavior had a higher risk reduction. Moving on to the partner study, one of the two studies, once again, that Health Canada reviewed. So this was amongst surrogate discordant, or couples where one person was HIV positive and one person was HIV negative. And the study took place in Kenya and Uganda. And there were almost 4,800 people enrolled, so it was a large study. There were three arms to this study. Arm 1 took one of the medications in Truvada. Arm 2 took Truvada, and Arm 3 took a placebo. And everybody took their medication daily. Amongst the participants, 38% were female and 62% were male. And that refers to the people who were HIV negative in the mixed HIV status couples. Monthly, people in the study were provided with HIV testing, were evaluated for adherence to Truvada, were assessed in terms of the sexual behavior they engaged in, and safety evaluations were undertaken. Specific to women enrolled in the partner study, they were tested monthly for pregnancy, and women who became pregnant during the course of the trial were interrupted in terms of taking Truvada, both while pregnant and throughout breastfeeding. In the partner study, we saw a 75% reduction in risk when comparing the people who are on Truvada to the people who are on placebo. The results also showed no difference in efficacy or risk reduction between men and women. And we will see a pattern in Truvada or HIV PrEP studies going forward from this time, that the study was stopped early when the data was analyzed along the way because it proved to be highly effective. And so it would be unethical to deprive people of the protection of Truvada for PrEP. Once again, efficacy or the risk reduction potential of Truvada was strongly associated with adherence. Now I'd like to talk a bit about the PROUD study, and this was one of the studies that Health Canada did not look at, and we'll briefly review it. Following up on the iPrEx and partners studies, there were questions that were outstanding. In particular, was there risk compensation among people taking Truvada daily for PrEP? Risk compensation in terms of not using condoms in the same way they had before, or less frequently using condoms, in other words, having more condomless sex. And one of the ways to get at that risk compensation is to look at rates of sexually transmitted infections, as well as self-reported behavior related to condom use. The PROUD trial enrolled gay and other men who have sex with men who are at a heightened risk of HIV, and enrolled about 550 participants. There were two arms or groups in this trial. One arm was given Truvada for PrEP immediately, and the other arm was given Truvada 12 months after the person enrolled in the study. And unlike the iPrEx and partners studies, routine clinical practices were provided. And these were the regular day-to-day clinical practices that would be observed in the GU clinics or the sexual health clinics in the UK where this study took place. Remember that in partners and iPrEx, people were monitored monthly, and there was a fairly intense dedication of resources to people enrolled in the trial. I think a slide has gone missing, but I can tell you that in the study, there was an 86% risk reduction. And the study was stopped early because, once again, it would be unethical to provide the people in the study who were not already on Truvada, to not provide them with the benefit of Truvada for PrEP. So, summarizing the evidence from the studies, we saw risk reductions in iPrEx, partner, and PROUD study among adults, men who have sex with men, including transgendered women, and heterosexual couples who had a different HIV status. Greater adherence in every study was associated with greater risk reduction, and the evidence comes from real-world clinical trials, like the PROUD study, and from controlled clinical trials like iPrEx and partners. We don't have enough evidence on the safety and effectiveness of Truvada for PrEP in people under 18. This is a population that has not been studied or studied well. And we have no adequate, well-controlled studies of Truvada for HIV prevention or treatment of HIV in pregnant women. Yes, the PROUD slide was out of order. So revisiting the real-world results of PROUD, as I said, there was an 86% risk reduction, and the trial was stopped early. And importantly, there was no evidence of an increase in other sexually transmitted infections or behavior change. So there was no evidence, in other words, of risk compensation. And there were no serious adverse drug reactions. While there were 28 adverse events, some of which resulted in an interruption of PrEP, people were able to go back on PrEP after the adverse events or side effects wore off. Continuing on with the summary of the data, Truvada for HIV PrEP has proven safe. There are no significant drug-related effects reported by participants in the clinical trials or the real-world trial, and changes in the laboratory results related to bone mineral density and liver function reversed after people stopped taking the Truvada. All studies have included HIV testing before PrEP is prescribed to ensure that people were in fact HIV negative. They've included ongoing medical monitoring and testing for HIV and other STIs and pregnancy where women were involved in the studies. They've also included counseling and access to condoms. And we have PROUD standing as a real-world example of the inclusion or use of Truvada for HIV PrEP in a clinical setting. So these trial results, specifically of iPrEx and the partner study, have informed Health Canada's approval and indication or prescribing use for Truvada as HIV PrEP. On the left-hand part of the slide here, we have a screenshot of the Notice of Compliance, which is what is issued by Health Canada when a medication is approved. And on the right-hand side, we have the product monograph, which is submitted by Gilead and approved by Health Canada as part of the drug approval process. The product monograph sets out the indication or purpose for which the medication has been approved. And the next 3 slides will provide information on the indication Health Canada gave for Truvada for HIV PrEP. So Truvada should be used as pre-exposure prophylaxis of HIV-1 infection. There are other strains of HIV, but HIV-1 is the predominant strain in Canada. And Truvada for PrEP should be used in combination with safer sex practices to reduce the risk, importantly, not to eliminate, but to reduce the risk of sexually acquired HIV in adults at high risk, and it should be taken daily. That begs the question, who is at high risk or heightened risk for HIV infection? The product monograph gives us some direction in this regard and provides factors that may help healthcare providers identify people at risk of HIV infection. Partners of people known to be HIV positive or living with HIV are considered to be at risk or heightened risk for HIV infection for the purposes of prescribing Truvada as PrEP. Other adults are also considered to be high risk where they're engaging in sexual activity within a high prevalence area, a high prevalence geographic area, or a high prevalence social network. So for example, an urban population of men who have sex with men where the HIV prevalence or rate of HIV is quite high. So people in a geographic area or a social network having sex and where the person reports inconsistent or no condom use, diagnosis of other sexually transmitted infections, engaging in the exchange of sex or commodities, the use of illicit drugs or alcohol dependence, where the person has a history of incarceration, or where they're a partner of somebody who has any of these factors listed. The product monograph goes on to instruct healthcare providers as follows, that they should prescribe Truvada for HIV PrEP as part of comprehensive HIV protection, or prevention, because Truvada is not always effective. They should counsel people about the need for strict adherence, because as we've seen in the clinical trials, the risk reduction is directly related to people taking the pills as prescribed or adhering to the medication. That people's HIV negative status should be confirmed prior to prescribing Truvada, and that people should be screened for HIV every 3 months while they're taking Truvada. Now it's your turn. Melissa is going to make the chat box a little bigger, I believe, so that we can